some more nitro there. Good. Keep it there.
Hello. Dr. Rony, Mathew, good afternoon.
Hi.
We are here from Mumbai. Are you ready with the case? I am Dr. Hiregowda here. I have Dr. Shetty here, Dr. Nicole, and Dr. Nitin Deshpande. Can you tell us something about the case, please?
Right. Wonderful to see you. Nitin, Dr. Narendra, and Dr. Nicholas, welcome to India. We're going to show you a case, a left main LAD lesion, and my colleague Dr. Jabir will present the case. But let me before that also tell you my team members. Sister Betty is there, Josmi is there, Wilson is our tech, Dr. Joe, if you can pan the camera that side, and of course we have got Dr. Musna, the OCT, and I'm sure Dr. Nicholas Amble from there will also be controlling the OCT machine, and he will also explain to you about the OCT findings. So Jabir, let's have the case.
He's a 60-year-old gentleman. He presented with effort engine of 2 months duration. He's hypertensive. A treadmill test was positive at 7 minutes of Bruce protocol. His echocardiogram revealed a good LV systolic function, and we'll show you the angiography. Wilson, could you run the angiography?
Okay, let's have the angio, right? No, not this angio, please. Let's go live. Yeah, let's run this angio, yes.
Now you can see the angiography which shows a proximal left main which is okay, but distal left main, there is some lesion in the distal left main with a significant stenosis to as it appears a tight stenosis of the LAD ostium, and down that ostial disease there is some more disease around 20-23 millimeter down, then the LAD appears normal.
Yep.
And the circumflex seems to be disease free with some minor disease of the first OM.
Go to the next view.
And there is a suspicion
Next
of a
view.
calcium at the mouth of the LAD, and the RCA is normal. So this is the case.
Now, before we discuss this case, okay, the RCA is normal. Go next. Right. So before we go and tell you what we thought, let us hear from you what your viewpoints are.
Good
there is
afternoon.
definitely some disease at the distal left main and the ostial LAD and proximal LAD. But how severe it is a question. You said TMT was positive. So
The TMT was positive, but
Okay. I think it's a good question that Dr. Prabhakar has asked. A good question. So I think let's go to the first part of it that we did. Let's go further. We decided to do a physiological imaging because we knew that there would be doubting Thomases there.
yes.
So go to the next one, next view. So what we do for a physiological imaging here, what we are going to show you is a full cycle flow reserve. It is an what's called RFR by the St. Jude's. So we did that, and we did not give adenosine here. Now, can we have a look at that RFR? Can you show us the RFR on the main screen, please?
yes, it's.
Yeah, so this is what the RFR showed us, distally 0.85.
So that's significant.
And of course, I did not give adenosine because it's 8.5 and it's significant. So show me the next thing. The other good part with this RFR is you can do a pullback. And you look at the pullback that I did. Can you show me the pullback, please? The pullback screen. Right. So that's a pullback screen that shows that from 0.88 it goes up to 1 across that particular lesion. So the lesion is definitely physiologically significant. Yeah. Now, what do you think we should do?
So it's a you need looks like a long stent. So covering the proximal LAD extending to the left main. So I would go for a single stent.
My strategy will
Yeah.
be the same.
Good.
To stand from the distal left main to the prox or maybe mid LAD and with pre-PCI imaging in order to correctly size the length and the diameter of the stent. And probably, I think a one stent
Let's do imaging.
strategy
Next, Nicholas.
would be, I think, to be proposed in as first option.
It's a big vessel. If you look at the digital LED, it looks like at least 3.5. So it's a big vessel. So you can use a 3.5 and you can go up to even 4.5 in the left main.
Dr. Prabhakar, do you think there is a significant calcium or something else at the distal LM and towards the roof of the proximal LA?
Run the LA
because we were a little worried about that thing.
Well, we are not able to see
is it
much
clear
of the
with the
calcium.
angiography that what is there? See,
there-
what do you think? Is it
So there is-
normal or is it abnormal at the mouth of the?
No, there is some calcium, but not bad. It's not looking bad here.
Yeah.
All right.
So what we initially from the angio, what we thought is that there was a lot of calcium, and especially since it was an LAD ostium, we thought we should go and do a rotablator and cut over there. But as Dr. Nicholas suggested, I think imaging is a must, and we did an OCT pullback. So let's go to the next one, please.
Shall we run the OCT?
Yeah, next shot to show the OCT. Next one. So I have run the OCT over there, and we have co-registered that. Dr. Nicholas, do you have control of the OCT there?
Yeah, so I think I have to come to the booth.
Can you just describe that? No, we don't see your cursor moving.
So now
Yeah,
we'll
that's
also
right. Now you
review
can
the,
see
the
that, yeah.
RAN. So the nice part is that we have a co-registration that will allow us to define and identify the potential landing zones. So first, let's review the RAN, and we see that there is a
That's
diffuse,
right. That's right.
there is a diffuse disease, but here we are in the proximal AD, and there is obviously a mixed fibrolipidic plaque that goes. You see, it's more severe than expected on angio.
Yeah.
The lumen is 3.45, and we go now. Oh, it's very tight here, just after the left main, and you see that as we could suspect on the angio, the distal left main is not free of disease, and you see that this is definitely the distal left main, and the lumen is 4.5. So definitely that's that's worth, in my opinion, covering this lesion. So now, if we want to process, we have to pick up and identify correct landing zone. So as you see, and as you mentioned, there is the left main, you see is not normal, so there's mite disease, but I think that here that could be an acceptable landing zone, proximal landing zone, and we're gonna go down and try to identify a correct distal landing zone. It is not bad here. If we do like this, that will be a 32 millimeters length stent. We can take something longer, but maybe 32 is the minimal
pre-dilatation
acceptable length for the stent. The distal
2.5.
we now go once again to the to our distal landing zone. So we're gonna measure the EL to EL diameter.
Yes, that's essential.
It's 3.2. So I think that you mentioned that you were heading to the angio, based on the angio, you wanted to use a 3.5 stent. So I think it's correct. And the prox. So the stent, the diameter EL to diameter in the left main is 4.5. So I think that we could, if we do I would go for predilation. Maybe I don't know if it you are keen about putting a wire in the circumflex or not. It's something that could be debatable. But I think using a 3.5, 32 or maybe 33 millimeter stent that you will pot up to 4.5 in the left main would be a good option.
Right. I think I do agree with you, Dr. Nicholas. Dr. Musna,
Nicole.
can you just take it on to that distal left main?
What about calcification?
Another one,
What about
yeah,
No,
that's what I want to
alright.
show you. So just go on to the distal left main and you know, so something that we surprisingly saw over
Yeah,
there.
right,
At the
right.
distal left main, you see a rupture plaque there at 3 o'clock to 4 o'clock position.
Okay.
Just take that and zoom that out here. Take that. Yes. That. With a little thrombus there, which we were a little surprised to find out there. So probably there's a small rupture. Though he clinically does not have an ACS, he had only effort angina with a positive treadmill. But we saw a small plaque rupture there. And let's go back and see there is no significant calcium. And that's very surprising. Though you see something on the angio, there is no significant calcium.
I agree. It looks more
Down in-
fibrolipidic rather than calcified on OCT.
Yes. So I thought I should go and pre-dilate that area in the proximal LAD before I go and try and put a stent.
I fully agree.
I will take a 3.538. Get that ready.
Okay, shall I go?
Yeah, go there. So I mean, see, the interesting part of this is down. The interesting thing is now, if we use a 3.5 millimeter stent, there's a big difference between a 3 and a 3.5 millimeter stent as far as the Zions group of stents are concerned, because, correct that, the 3 millimeter down, the 3 millimeter stent is actually a 6
where?
crown, and a 9 millimeter,
Nine.
not a 9, I'm sorry, a 3.5 millimeter stent is a 9 crown
crown.
design. So the entire design changes from a 3 to 3.5.
Rony, are you happy with?
So if I use a 3 millimeter stent, the maximum. What was that?
No, are you happy with the expansion of the balloon in the proximal ostial LAD? I would use a cutting balloon here.
No,
because-
I'm not. No, I mean, because I saw a rupture plaque there and a lot of lipid there, I would be hesitant to go very aggressively there. I would think of going with a stent directly and going and post-dilating the stent. Unless I really saw a lot of fibrotic plaque and calcium. I mean, I was in fact planning a rotablator, but I think unless we really get a lot of fibrous, I don't think we should use a cutting balloon. We may have slow flow.
But I thought your pre-dilatation balloon didn't expand well in that area. So the very proximal ostial.
I agree.
So
Agreed.
I would be comfortable using a cutting balloon here, because you definitely have to prepare the lesion better for your stent expansion, because after the stent deployment, you know, whatever you do, sometimes you are not able to get the proper expansion.
Let us show me a LA caudal view. Let me see an LA caudal view, see how much we have expanded.
Exactly this 5130. Yeah, this is.
Yeah, I
this is
think
expanded.
yeah, that would be sufficient, yeah. I think now what I was alluding to was the fact that if you use a 3 millimeter stent over here, the maximum diameter that stent can be blown up to is only 4.2. That's what the manufacturer recommends. But if you use a 3.5 stent in this particular situation, you can go up to 5.7 or 5.4 millimeters. So that is why I think in this particular situation, though the distal part of the LAD is only 3.2, I would use a 3.5 millimeter stent, deploy it at not so high pressures, and I'll show you an OCT before we go and do.
Little more.
What would you think of that?
We may go a little more in because of the hose.
I need
We are up to-
8 millimeters there.
Yeah, we are up to the hose almost.
See, another thing is we need at least 8 millimeters in the left main to do a decent pot. So I would be putting some amount of stent there in the left main.
Shall
Can
we-
you have your LA
Yeah,
caudal
LA
view
caudal.
before I go up?
Now I can.
That would be fine. So you just
Shall
go
we-
up,
shall I go?
but don't really release at low pressures. Go to the other view, please.
It's 10.
That's enough. See, as Dr. Prabhakar pointed out, we do not have grade inflation at the Austral LAD, which we will go and optimize with a post dilatation before we do an OCT and show you that.
He is complaining.
He's having discomfort. Get some nitro, please.
We have the bill.
Right, that's okay. Some more nitro.
Fine.
That's fine. Now, get me 3.5 NC.
15.
Yeah, that would be fine. I'll just give a
3.5,
shoot
15
before we
NC.
go with the.
Yeah.
But you're choosing a 3.5 by 15 NC.
Yes.
I also, have some. I think there's some difference in using the
Okay,
length of the
expansion.
NC balloon for post dilatation. If you have an under-expanded stent like that in the middle,
Mhm.
I would use a very short NC balloon, like 8 millimeters. And I can go to very high pressures. The expansion with the very short balloon will be different than a longer balloon, even in the NC range.
Mm-hmm.
So if I see any
Yes,
under
I do
expansion-
agree to that.
Yeah, any
Uh,
under expansion of the visible, under expansion of the stent during an elective angioplasty, I would prefer 8 or 10. And only in the acute MI situation where you expect the stent to be, on the angiogram, stent expansion looks very good, then you can use a longer NC balloon for post dilatation.
Elio caudal, please.
Or distal
Wha-
bar.
What I don't want to do is I don't want to be doing a carinal shift in this particular situation. Therefore, I will go and just dilate here with a 3.5 before I go further.
Okay, it's in
Go dilate there.
I'm at 12, 14,
14, 16, 18,
18, 20.
down. നെഞ്ചിൽ ഇച്ചിരി ഒരു പ്രയാസം ഉണ്ടായിരിക്കും കേട്ടോ. We are going up with a higher pressure balloon.
The other view.
Other view, please. He's complaining of a little bit of a precaudal discomfort, but I will just go ahead and do it.
I'm
Yeah,
going.
go up.
16,
16, 18.
18, 20.
Down.
Shall we come back and do it again?
Now I'll take a picture
yes.
in the LA. You want me to go once more there? Yeah, we'll go once more there.
Centralize it. And go.
I'll take a 4 millimeter 8 balloon for a pot.
This is now 20 atmospheres.
Down. But when we go at high pressures in the proximal LAD, the worry always is that we are going to cause a carinal shift towards the circumflex, and that's why I'll give you an iliocaudal view to see that point of view. Give me a 4 for a pot,
So then,
and let's get a OCT done.
NTG.
NTG.
We may take it 4.5 for the port because it is 4.5.
Or do you want me to do an OCT and then subsequently do a pot?
Ronnie, why are you not using a 4.5 for pot?
Yeah, we'll use a 4.5. I do agree with you, Narendra. I think we should be doing that. let me first give you an OCT picture of this. I mean, let's have an OCT before we do the pot.
Sorry, what was
And
the-
so that we can make out the difference. I mean, it's another course. I mean, it's also teaching for us. So let's see what the difference that pot does make out. And I think it's very interesting to see that on OCT. Let us just put this.
Yes.
No, I go a little bit more. I want to go right up to the left main.
Okay. Pressure.
Right. Okay. So get the OCT please on the main screen. Right. Live view. Calibrate. Right, so let me do the good. So let's have a look at this OCT before we decide what you're going to do with it. You want nitro? Why? Okay, set it. Dr. Nicholas, do you have control of the OCT machine so you can describe that OCT for us?
There is position.
Show me scene minus, Wilson.
So,
Scene minus. Heliocaudal view.
at first sight, it looks pretty okay. So maybe some concern about the expansion on the prox LED, but we're gonna measure that. And actually, the panel was a little concerned by the because you use a 4.0 balloon for the pot, and actually here you see that on the very proximal part of the
Go to the rendered. Oh, see, he's controlling.
Yeah, there is malposition there. I need the heliocaudal view itself here. That's okay, but I'll need the
Sorry.
heliocaudal view itself.
So there
You
is
can
a
adjust the
malposition
camera.
that you can see here that we have to correct maybe with probably a bigger balloon.
4.5.
What do you think the size of that balloon should be in the left main? A 4 or a 4.5?
I will suggest a 4.5.
4.5. 4.5.
We
Yeah.
are-
8.
And let's
Right, I do agree that because there it is at least 4.3 over there with an EEL of 4.5. Can we go to rendered stand and a bifurcation view where we see the bifurcation of the circumflex, please?
Yes. So now we have the bifurcation
Yeah,
view.
you hold this, you look at constantly.
So
I wanted to
here,
show you,
that's-
you
that's
look at
quite
that, there are struts right across the ostium.
Yeah, we'll see that. I'm just okay.
I will keep the
And we
circumflex
get-
wire there
we're
when I
going-
do the pot, not a problem.
And this is the ostium of the circumflex. Okay. So, Dr. Mathew, what will you do with these gel struts? We'll try to recross and side dilate.
Yeah. Yep. That's what I would do. So see here what I'm going to do is, I'm going to first do the pot so that I will try and push that strut away from the ostium.
Yeah. So you have to recross.
If I'm not successful on OCT, I will cross it.
Okay.
Can you keep the balloon a little bit down?
Can we go back to the live view, please? All right. So that's when I'm going to do a pot for the 4.5. Go up 4, 5, 6,
8,
8,
10.
10.
One more.
Down. And I think it's very important to know the position of the pot. As you know, I think that is something that you all can discuss over there. So go up again, 6, 8, so that we just have a shoulder right at the ostium or the circumflex to push the circumflex struts into the circumflex ostium. 10. So that's
12.
exactly what I'm doing over here.
12.
12,
12,
14,
14.
down. Now let's do the OCT once again and see what we have achieved with the pot. Angio stent view to see if we have reached the proximal part of the stent in the left main. Get me an RAO caudal view. I want to check if we have touched the proximal part of the stent in the left main.
We have our marker was
Exactly the proximal?
Exactly at the origin of the stent.
Are we sure about that?
With a little overhang also below.
Let me, we will do a clear stent, we'll see. Right, perfect, good. So I will now do an OCT. Thread the OCT. Now this is, I think, an interesting point which Dr. Nicholas said. That if we have a strut across the circumflex ostium like that with a large connector, can we go back to that view please? Get me that OCT view please. And if you have azines basically is made up of crowns with connectors. So if you have a connector like that right across the L-Cirx ostium, I think that strut should be removed from there because that's going to cause neointimal proliferation and restenosis at a later point of time. Okay, let's have a quick image of that. Go to rendered stent. Rendered stent. Right. See, so if we look at that, you have exactly two crowns and a connector across. So now I will do this OCT and we will see what does a rendered 3D picture looks after a pot there. Okay, let's go to live view please. A new recording. Live view. Calibrate.
Yeah.
No. Linda, don't disturb, please. Okay, give me another. We can't have blood there. Do not disturb when the recording is going on.
Okay. Now we have to flush it. What is that?
Now he is vomiting. I think he has a little pain also. So let's just settle him down before we do this image. Are we on live view right now?
Shall we give a little of hydrocortisone also could be a contrast?
Mathew, you've been talking about
Calibrate.
these struts across the.
One second. I'm just doing this pull back here. Right. One second, don't pull. Right, let's have a look at that recording and let us decide about that. Can you get OCT to the main screen, please? Good. Get me a rendered image of the bifurcation point. Call them no. Let us.
Pressure is fine.
That's all fine. Everything is fine. Just comment on that.
We may give a ME set also.
Dr. Nicholas, what do you think?
I think that you did a very good job in the proximal part of the stent, because now we don't see any Malapo strut, and here that's the same image. So I think that the pot has been nicely done, and I think it's okay now to try to recross the distal one of the distal cell of the stentlet.
Okay.
Let me just focus. So we have two potential struts that could be not strut cells that could be crossed, and because in order to get a good result, we need to cross a cell that connects to the carina. So it might be this one or this one. It's
you discuss it. Keep discussing.
okay. This one or this one, and
yeah, I think
that this one is maybe easier to cross. What do you think?
I think this is something that we really do not have data about, but that's something that we need to discuss about. At this point of time, should we just leave it like this, or should we be doing a kiss to the circumflex ostium? I agree with Dr. Nicholas to one extent that we should be doing a kiss and getting that strut across the circumflex ostium, but that is something that I would want. What does Dr. Prabhakar, Dr. Narendra, Dr. Nitin all feel about it?
Hey, shall we see the angiogram? The LAO quadrant?
One second. What I'm doing is, let's go back. What I'm doing is, I'm just trying to do a distal cross here, and try and confirm it on the OCT that it's a distal cross, because only with a distal cross will I be able to then go and do a kiss. So I have tried and crossed it distally, and I will confirm that again with an OCT. Put a talker on this circumflex, and give me the OCT once again. It'll just take me another 3 minutes to show you the OCT if I've actually gone in through the distal strut, and that is something that I want you to concentrate on, and if it's a distal strut entry or not. No, not now. What I do is, I normally leave that jailed wire into the circumflex. I leave it jailed until I decide that I'm going to do a kiss, and at that point of time I remove the jailed wire. Right, let's get ready for another injection here. Okay, let's go to the OCT view, please. Live view. Wait. Let it come there. Yeah. Press the calibrate.
Okay, Wilson. Enable. Yeah.
Now, please tell us how we have crossed.
Okay.
The injection is not a very great injection, but let's see. The patient has a little precordial discomfort, I think, because of the expansion, and that is why he's a little restless. Rendered stent?
Yes.
Rotate it and tell us. Yeah.
Yeah, I think it's
Sometimes, as in this case, but what has happened is, it is.
I believe that Yeah, I think that you are in
2.75
one of the
New York
distal,
and a 3
one of the
and a 4.
distal cell. Not the initially largest one, but I think that's you're good in good positions to go
Remove this out.
Not 4.5.
I remove that
further
out.
in
This
the
is
in the
the
process.
2.75.
Yeah.
What do you think?
Yeah, what I think is that, you know, in the sense, I think there is a crown and a valley. So the wire has gone in through a distal strut, but it is limited by the valley, and that is why it is not. Otherwise, the wire would have laid on the proximal part of the side branch. So I think it's a distal cross. 2.75, please. So I'm going to do a kiss. We'll probably. What do you think should be the size of the balloons for the kiss?
Huh. It's supposed to be the size of the prox circumflex, so I think maybe a 3.0. I would need to
This is
get back to the angio view, but
2.75, you said, or
we could also calculate that from the Murray's law. If it's a 3.5 in the ostial circumflex, in the ostial LAD, and a 4.5 in the left main, it should be 3.0 would be my choice, Dr. Mathew.
Right, so that's what I'm going to do. I'm going to do put that into the circumflex. But what do you think should I put into the LAD left main? A 3.5 or a 4?
I think a 3.5 and 3.5 in the LAD left main and 3.0 in the circumflex left main will be enough.
3.5, 12 and
because
by?
you already have a nice apposition in the left main, so I don't think you need to get to a larger diameter, and 4.0 might be a little too much, in my opinion. But I don't know what
Heliocaudal view.
Yeah, I think even in the absence of OCT, we would have
Balloon?
used that kind
Not
of
that. 3.5
combination.
New
3.5
York,
yeah.
12.
Yes.
Enta ivide? Jabir, please let's move fast.
So
Right, so what I'm going to do is I am putting a 3.5 into the left main LAD, and I'm going to put 3 into the circumflex, and we're going to do a kiss. And after we do the kiss, we will give you a final OCD picture, and we'll show you how it looks.
Ronnie, are they NC balloons or semi-compact?
So, no, we both are NC balloons.
Ronnie, while you are doing the kiss,
So here what I normally do this is I generally always do a very soft kiss on this, because we do not want to dissect the circumflex. So we will not go very high on the circumflex balloon as far as the pressures are concerned, and it will be low pressure kiss. So it's just to remove the strut out. So first I remove the strut out by only dilating the circumflex to around about 4 to 8. Go negative on that. And then subsequently do a soft kiss.
Okay.
Let's go. 2, 4,
4,
6, 8,
8,
10.
10. A little more. 12.
Yeah.
12.
Negative. Right, so that's the kiss that we have done. It's just to remove the strut out of the circumflex ostium. And I'll show you a last OCD picture before we complete this case to show you how the struts probably have made a difference. That's the circumflex. Keep it there. And this is the LAD. And I need now the OCT.
OCT. Okay. Ready.
So I'll just give you a picture before we thread the OCT. The LED sure looks good.
You are on the wire, isn't it?
I'm on the wire. get ready for the next
20 cc, 20
shoot
cc.
of the OCT. Okay, now what happens is generally this, that once the OCT wire has been used 3-4 times and the OCT decides to be a little stubborn, at this point of time what we normally do is we try and catch the OCT wire, the OCT with the wire, and push it both together, and that way it sort of goes in a little smooth, but at the same time be sure that your distal wire doesn't go and damage over there. You see how I've done it? And that's probably the way to do when the OCT wire becomes a little stubborn.
Live,
Let's go to the live view. Can we go to the OCT here, please, on the main screen?
calibrate.
Right. Calibrate.
Okay. Enable.
Good. They're doing the pullback.
Yeah. Good. Good.
Okay. Let's have a look at that pictures and see how they are. Wait.
Rony, by the time you are reanalyzing the picture, how many times can you avoid a kiss by using OCT like this? Or maybe you just do a side branch dilatation and do a final OCT once you have been using this routinely for left main. So how many times have you been able to avoid the recrossing of a strut?
See, actually, we have been doing. Can you come to PA view on this? We have been trying to do this for the last about 3 years, trying to analyze the strut across the side branch, and that's one of the reasons we chose this case also for today's live transmission. It's only in about 30% to 30% of cases when you really have to go and do a kiss. Otherwise, generally, you are lucky that the struts are really not there. Now look at this ostium. No, rotate it a little bit more. Look at that ostium. See, now that ostium has been cleared of that strut. See that? And I think this is a much better picture to leave the patient with, because there will be I have pictures in which we have neointimal proliferation that has occurred over the crowns of the strut, and the ostium of the circumflex has become small. So when you leave something like this with a strut that's open, you feel a little more comfortable, that's all.
Only the issue here is that one, you are doing multiple OCT studies and increasing the contrast load, and secondly, you are also doing a dilatation of the circumflex and mildly injuring that, increasing the risk of restenosis. So there may be a trade-off doing this versus just leaving it alone when you have a very good flow and there is no compromise of the ostium. So unless we have solid data, I mean that's what I think you are trying to generate. So this is not something we want to practice routinely. What do you say?
Entirely agree with you, Dr. Prabhakar, but this is something that I think requires a thought process, because we have now in our 25 patients or so, we have 4 patients in which when we have left a strut across, we have had a neointimal growth that has taken place and the ostium of the circ has become small. So this is something I think which we will need data over time, but right now this is how I generally do. I'm not too sure if I'm right or wrong, but it'll leave the ostium good. Dr. Nicholas, what is your viewpoint on the whole thing?
I'm sorry, I was working on your images, and what was your question? I'm sorry.
The question is, doing this dilatation, kissing dilatation, looking at the OCT and the struts crossing the ostium circumflex, does it offer any clinical advantage to the patient? Because there is some trade-off, because you're doing multiple OCT runs, giving more contrast, and injuring the circumflex ostium. So it's not like absolutely risk-free. So unless we have more data to do this, are we justified in doing this? What is the data so far? Whatever data we have on this.
Unfortunately, we don't have
No data.
What is the incidence of restenosis when you have absolutely no disease at the ostium of the circumflex and it looks very good? I think it's very, very small to start with. So when we are talking about that data, then it becomes difficult to justify. I mean, this can be done as just a purely research project at this point, rather than as a clinical practice.
I mean, we don't have that much data. I mean, in my, as far as I know, just the largest series I've seen is the one from Dr. Mathew that he presented at EBC, and
Can we go to the 3D bifurcation view again?
I think that just
Yeah.
yeah.
No, I think what Dr. Though that's not the bifurcation, but what Dr. Prabhakar said is very important, and I think it should be appreciated that unless if you really do not have a visible angiographic stenosis at the circumflex, what is the chance of restenosis? It's less, but and that's acceptable. However, I think when we have some pictures that say that, you know, if you leave a strut right across the circumflex ostium, you have a chance for neointimal proliferation that has been observed and decreases the size. We need data for this, but until then, probably, I mean, I don't know, we could either have different people thinking and different viewpoints on this.
It may not be easy to get data on that, but what we have seen in last couple of not couple of cases, maybe 20-25 cases, we had 4 cases where a neo-carina formation at the strut which was across the circumflex ostium, which produced a significant restenosis. You may consider it as anecdotal reports, but insight is given by OCT, which only comes late, which we have been guided by the angiographic pictures alone for last many years. So it may be a new thing, but we have to study it.
Yeah.
Dr. Prabhar, what do you think about it?
Rony, see, so there have been studies which are looked at routine kissing dilatation after, you know, single stent and versus no dilatation, and they have not found any difference in the outcome. So that implies that there may not be a significant advantage, even though this
Good.
sometimes.
Show me the pot and
Having
the
said
side
that,
branch there.
Prabhakar, about those studies are all few hundred patients in each arm actually, not very large studies to have.
Are
either
they
way.
enough
Actually,
powered for
this is
outcomes?
Ronnie, we have, I think, couple of minutes left of the transmission time. First of all, let me congratulate you for demonstrating
thank
excellent use of OCT in a left main bifurcation. And before we go off air, if you have some concluding comments from your end, after that I would request Dr. Nicholas to have his final comments on this case.
Right. Thank you, Nitin. Thanks for the nice words. But I think before we go off, we have shown this. I think we should discuss this. But before I sign off, at least let me thank you all on behalf of my team here. Dr. Jabir, me, Joe, Sister Betty, come here. Come, Joshmi, Wilson, our tech, Anu, come, and Musna, who is our OCT expert at the moment, if you can see her. She's pretty shy, but she has done a lot of work on OCT. In fact, the thesis was also on OCT, and we hope to be continuing with this. Thank you very much from our end.
Nice job.
Thank you, thank you.